like to transition into our Q&A session. And we have many, many questions. I'm going to apologize ahead of time and just let you know we will not be able to get to all of them tonight, but I'll try to organize and structure asking the questions in categories that are reflective of the various questions. So I'm going to start with this first question. The question is, as leaders of large organizations, how do you plan to recoup lost revenue during the COVID response efforts, which is, I believe, a great question and something that we're all focused on, obviously. And where should other leaders look to save dollars since we lost out on months of elective surgeries and procedures? And I'll start, perhaps it looks like Art's ready to answer that question. So
Yeah, well, I wish I had good answers to that. We're struggling like everybody else, to be honest, but a couple of things. So number one, we're clearly getting resources from the federal government. The question is how far those resources can be stretched. So under the CARES Act, there's been distributions of hundreds of millions, billions of dollars to New York hospitals, and there will be subsequent distributions. What we're challenged with right now is that every day that goes by and these distributions do not occur, when you do the calculation that's required under the legislation that was passed, more of the dollars are going to be distributed to other parts of the country, less to New York, because more of the rest of the country is seeing more and more COVID cases relative to New York. So it's very important that we get this next distribution and that we fight like hell for the next round of federal relief to obtain additional resources for our hospitals. So that's one bucket. A second bucket is money that we can recoup for expenses that we incurred to prepare for COVID, and that's money that we would get reimbursed by FEMA. And that's an unknown number, but it's material in all of our hospitals. Number three, there's the possibility of getting Medicare advances from the federal government. Right now, the payback period for those Medicare advances is really tight, and the interest rate is really high. So we've got to try to negotiate a much lower interest rate and a much longer payback period. That would at least give us cash to be able to, again, withstand some of the challenges that we are certainly going to be facing over the next over the coming months. Number four, we've got to figure out how can we crunch our operations safely, and buy time for when the volume starts to return. So, we've consolidated units that were never consolidated previously because they were always full. So, now that they're not full right now, we've compressed our units. We're putting hard stops on overtime, agency, traveler, and other premium labor expenses. We're leveraging the shared work program at Mount Sinai to, again, reduce our payroll costs for a period of time. And again, hopefully the volume starts to pick up. We're trying to centralize some of our operations, which are previously distributed, to reduce our costs. We're identifying where we can have people work from home to reduce our real estate costs. So there's a series of things that we're doing to try to skinny back our operating expenses, again, to buy us the time to when the volume starts to return. So our hope is, and not only by the time till the volume starts to return, but to stretch the federal dollars that we do receive and make it go as long as possible, again, until volume comes back.
Thank you. I don't know if anybody wanted to add to Art's response. Dr. Marshall, it looks like you may. No? Okay.
No, he covered it all.
Okay, terrific. This is a good question. How are you dealing with burnout for clinical staff and administrative staff? So maybe Dr. Marshall, you might want to talk a little bit about that.
Sure. Yeah, I think we've all seen that in our staffs. I mean, in the beginning, they were working, 12-hour shifts under extremely challenging conditions at the very best. And I think that as things started to calm down, once we had the apex and things started to slow down and we started seeing fewer patients coming in and being admitted with COVID and dying of COVID, and the adrenaline rush that all of our staffs had those first 6 weeks or so is now starting to wear off, and now they have time to think. And so all of that, they all have post-traumatic stress disorder. And so one of the things that I know we've done and other organizations have done is to provide respite care, counseling services, meeting rooms within the hospital itself where people can go and just take a break, you know, and talk to somebody, having counselors available. And I think those are some of the things that we will need to continue to do for the foreseeable future, because this is going to have long-lasting effects on our staff. And as I mentioned on our leadership calls in the evening, I tell people, please practice self-care. Take care of yourself so that you can continue coming in and doing what you do, so we don't force burnout. So.
Now, the psychological services are extremely important, and
Yeah.
you know, we're doing the same, and we have a respite area that we have closed off for our staff. And so if they need any type of service, or if they just need a break from the unit, they have an opportunity to move along. And we have to think about the next phase and what that looks like. I mean, someone mentioned before PTSD, you know, we have to really think about how we care for our staff so that they have a sense of well-being, and they feel good about coming to work every day. I have a question about telemedicine. So the question here is, will telemedicine and health reimbursements and guidelines be changing post-COVID? Do you think that they will? And will you be increasing the utilization as a community health tool for the use of telemedicine? And are you developing new spaces to support these activities for patients and providers alike? Anyone want to take a stab at that? Art?
Yeah, I can try.
Okay.
You know, we have temporary rate relief for telemedicine, right? That during the pandemic, the telemedicine reimbursement has been increased so that it's comparable to a visit, an in-person visit. So one of the things we've got to do is make sure that as the crisis ends, whenever it's declared that it's over, that telemedicine reimbursement rates are set appropriately, because it's not a novel tool or technology. It's not being used in isolated instances. Increasingly, it's being used as almost the primary way in which patients interact with their caregivers, to the extent that they don't need to come in and be physically seen by their caregivers. So, you know, I think it's going to be very, very important that there be a permanent reimbursement structure that provides for the appropriate use of telemedicine on a prospective basis, because it's now embedded in how we expect to receive care and how we deliver care. And we're organizing ourselves increasingly, and I'm sure, Carol, you're doing this and Dr. Marshall's doing this. We're organizing ourselves to do that. We're creating spaces to deliver, you know, virtual care, where, you know, we're utilizing waiting areas less and less because there's less people coming in person. It's had a remarkable effect. It's a good effect. It should be kept. It should be part of our care delivery system going forward. It can only be part of our care delivery system going forward in a meaningful way if the reimbursement catches up and is permanently changed to be consistent with what we've seen during the pandemic.
Thank you, Art. I think, Dr. Marshall, it looked like you wanted to respond as well.
Yeah, I think Art is absolutely correct. I think that telemedicine is going to be a huge part of going forward in terms of how we provide healthcare, and not just by the providers, but also the social workers, the nutritionists, physical therapists can do home visits by video. I mean, we have lots of opportunities where we can provide services without the patient having to leave their home. But as Art mentioned, the payment structure has to be appropriate so that hospitals will be encouraged to continue to use video telemedicine in order to provide these services. And I think in the long run, it will only make our patients healthier and happier.
Absolutely.
Thank you. Antonio, I don't know if you have anything to add in terms of any data that you have associated with the use of that technology. Antonio, you're muted.
Yeah, I think technology and data can be very helpful in preparing for a second wave. There is a high risk that this could happen, especially in the fall. So I can give an example of how data can be applied and used by the healthcare providers to monitor and potentially mitigate the risk of a second wave. Because from one side, we need to reopen economic activities. That's important to avoid an economic collapse. On the other side, it's paramount to do so in a safe way. They can mitigate risks of new outbreak. Since mid-March, we teamed up with the CDC, for instance. I can give you quick examples. So in March and April and May, we monitored constantly mobility and shelter-in-place indices per county or census block group level. So we were able to provide a picture statistically, because we see a subset of the American people, but representative. We were able to provide a picture of how people were complying to stay-at-home orders. And the CDC used this data for creating situational dashboards to understand where the risk was at neighborhood level, right? In order also to target public service messaging campaigns, or potentially understanding areas that were a higher risk. Moving forward, now we introduced a new important data point, which we call contact index. Now America is reopening, pretty much all states are reopening. The question is, people are moving, they're almost back to normal in some places, but how they're moving? Are they moving safely? Are they respecting social distancing? The contact index is an aggregate KPI that tells us a county level, compared to a pre-COVID, how many contacts, close contacts, we are seeing at aggregate level. So for instance, if you have a state that is reopening and the mobility is going back to the pre-COVID level, but the contact index is growing more slowly, that's good news. That means that people are more in control of their contact networks and of their social distancing. In high density areas though, like New York City, this is very tough. A slight increase of mobility in New York City can lead to a much faster increase of contact index, because people are less in control of their social distancing as they are exposed to people in the moment that they go out of their doorstep. So for instance, this suggests that a one-size-fits-all strategy may not be the right one. We believe that the strategy of Governor Cuomo in New York is actually very interesting, because it's not even one-size-fits-all inside the same state. So it's a differentiated approach, data-driven and metrics-driven. Also, this data can, if there is an outbreak, that's another focus, flows of movements between counties and census block groups. If there is an outbreak in a given census block group, it is possible to estimate where people are going the most and potentially, concentrate testing in the destination areas. So one key component for mitigating the risk of a second wave is the selected testing, right? So the possibility to identify immediately areas of risk, and data can support that. We can identify people coming a high risk port of entry, and an aggregate level. All of that is aggregate, privacy safe, granularity that in any shape or form puts the privacy of the individual at risk, but can provide a lot of insights about the risk of infection, especially if there are new outbreaks either in the United States or even abroad, of course, with people coming inside the United States. So these are quick examples of how technology and big data can really play a paramount role in the pandemic response. And, it is important that there are used these tools in order to, mitigate the risk of a second wave.
Thank you, Antonio. That was a great comprehensive response. I appreciate it. Something that we touched on earlier this evening around social determinants of health. There's another question here that I think is quite relevant, and maybe we can delve into it a little bit more deeply. Social determinants of health were already impacted, have already impacted the health of individuals, So how are your organizations preparing for another potential surge relating to COVID, and what are you doing to address those respective populations that can be impacted significantly? And I'll throw it out to whoever would like to respond.
That's a good question. I think it's not so easy to answer. I think that as we look forward and preparing for the next wave and trying to anticipate when the next wave might occur and looking at social determinants of health, I think one is our telemedicine services will help in identifying those people that are at highest risk because of social determinants of health. The areas where our hospitals are located, especially in underserved areas, and those hospitals that are mentioned like Brookdale and Interfaith and Kingsbrook Jewish that are safety net hospitals by themselves, and they're in neighborhoods where the community is highly impacted by this pandemic and any pandemic that comes after. So we really have to see what resources are available, working with our community-based organizations to provide identification and services to some of these communities so that the impact of disasters, whether it's a pandemic or any other type of disaster, does not affect them more than other areas. So I think that we have to think about that. I think we have to really come up with some novel and innovative ways to help these communities, identify these communities, and get them the resources that they need so that they aren't impacted as much.
And sometimes it's bigger than the organization. And, you know, Art alluded to it earlier about working with government to broaden communication, to broaden the availability of supplies, to broaden the way that data may be shared. But certainly, you know, on Long Island, we've been partnering with local governments to coordinate communication and education to assist various populations in the area.
And you know, Carol, I'm worried about the condition of the smaller not-for-profit organizations that provide social supports in addition to the smaller clinical care providers in these areas. You know, so one of the things that we're doing at my hospital and within the Mount Sinai Health System is, you know, we're surveying these organizations, is trying to find out what's your status. You know, are you still going to be able to operate? Do you have enough funding? You know, are there demands for your services right now? Are there different demands given given what's occurred? You know, I think that there's a lot we don't know about what kind of services people are going to need and what the condition of the service providers are in the communities of the vulnerable communities that we all of our hospitals frankly serve. And that's work that we're going to have to do. You know, and many of these smaller organizations are so dependent upon government grants that those government grants may dry up because the state doesn't have the resources to be able to provide them, or local governments may not have the resources to be able to provide them. So there's going to be this downstream ripple effect that's going to hit these organizations, and it's going to undermine the work, frankly, that we've done over the last several years through DISRIP in building these organizations up and partnering with these organizations over the last several years, that I'm very worried about their condition prospectively. And we're going to have to think strategically about what we need to do as good partners to try to rebuild in some of these services, you know, as we start to figure out which organizations are still able to provide services and which ones simply, for whatever set of reasons or for financial reasons, just aren't anymore.
It's a lot of food for thought, and it's an important topic that we all need to consider and focus upon. So I think that this is a good question to end on. This will be our last question for the Q&A session. And the question involves planning for the second surge, the potential second surge. We've all alluded to the fact that there are multiple models out there. We really don't know when and if it will hit, but we certainly want to prepare. So what are your organizations doing, perhaps even differently than the first surge in terms of preparation? Dr. Lewis, I know you're the CMO in a heavily hit area. What are your thoughts?
So I think as we prepare for the second surge or the second wave, whenever that may be, I think that we've learned so many valuable lessons in preparing for what we have been through the past 90 days plus. So identifying additional resources, creating ICU flex beds and how to do that, having staff who have never worked together in a hospital come together and work together, having surgeons on the medical floors taking care of medical patients because they're not doing surgery, having ER docs working on the floors because they had critical care fellowship training. So, you know, things like that. I think we've learned so much in the past 90 days that I think that the next wave, we just need to make sure that we keep track of all the advances we made and then be able to deploy them or employ them as soon as the next wave hits. And I think that one of the things that we're doing is all of the ICU flex beds that we've created, we're leaving the infrastructure in place and adding additional infrastructure in areas that didn't have it. And I'm talking about things like oxygen and vacuum, things like that. And it will be there for the next surge. And when it comes time, we'll be able to move one unit to somewhere else and then turn on the switch and open up those ICU flex beds if we need them. So I think that that's what we've learned in the last 90 days, and we'll keep that in mind when the next wave hits.
Thank you so much. I just really, truly want to thank all of the panelists. You've been really terrific in terms of responding to the questions and providing some insight for those who are participating in the webinar. So thanks to all of you. At this